So we'll talk just a little more about some of the concepts in week 3, just in a little bit more depth for your benefit. Some people, I think, learn better from hearing the information in a lecture rather than having to read it or just read it. So hopefully you'll read it too. But like I mentioned, clinical assessment and diagnosis is key in this chapter, and it's key to when we're working with clients and really gaining a comprehensive understanding of what's going on with them. It's a systematic evaluation and measurement of the psychological, biological, and social factors that are contributing to the individual having a psychological disorder, if there is in fact one. So we want to make sure that we're using reliable and valid and a standardized method for which we're doing these things. So reliability refers to kind of in general the consistency to the method that we're using when we're evaluating. Validity is how accurate is that assessment that we're using for the particular diagnosis. So if we're using a measurement like the Beck Depression Inventory for depression, it is valid. It's been tested. If you use it, it does purport to measure what it's measuring. So it is measuring depression. It's been tested and studied and compared to other measures of depression. And so it shows that it is. It's consistent across people who suffer from depression. And so that makes it reliable. And then it's been standardized. So it's been held against norms, a normative group. So these are important components. So when we're thinking about methods for assessment, we often will start with something called a mental status exam. So many times patients will present with symptoms that look like it could be psychological, when in fact it could be neurological or it could be something biological. And so the mental status exam gives us a kind of a screening to see if there's anything going on that we would want to be looking further for more medical appointments. And there's all kinds of categories in the mental status exam, so be sure to read about that in your chapter. Thinking about behavioral assessments, that's another method for doing things. And so a lot of things can be, or a lot of tests can be used for behavioral observation. And so this relates to kind of formally assessing someone while they're doing things. So we can look at what maybe their thoughts and feelings are in a specific context as it relates to their behavior. So think about what potential problems might exist when we're doing a behavioral assessment, and what should we be looking for, and what kinds of things might come up with that. And so those are going to be kind of observation of behaviors. We do things like that in particular in like residential programming, where we're constantly kind of watching over behaviors and what's going on with them as they're in the unit or in the milieu. When we're thinking about diagnosis and we're looking at using the DSM for the criteria, it's a classification system. And so this term refers to the idea that it's going to group or categorize people based on shared attributes or shared characteristics. And so that, and it's based on certain dimensions, and it's prototypical. And so our current system, which I've mentioned, is the DSM-5. It's based on a prototypical approach where certain essential characteristics are identified, but certain non-essential variations don't necessarily change that classification. And so DSM-5 categories are based on empirical findings in order to find or identify the criteria for each diagnosis. And this system is the best one in terms of its scientific underpinnings, but it's far from perfect. And research continues to be the most useful way for us to classify psychological disorders. And so the DSM has been through several revisions, and the DSM-5 is the most recent revision. And so the most notable change in this particular revision was the removal of the multi-axial system, which has been in place since the DSM-3, I believe. And the first 3 axes were combined into descriptions of the disorders themselves, and clinicians can separately comment on psychosocial or contextual factors. Formally in the DSM-4, it was the axes. And then also clinicians will report on the extent of the impact that this is having on a given condition, if that condition exists. It's also a dimensional approach, and this dimensional approach has its advantages just in terms of it being more comprehensive in its descriptions of the client's behavior or what you're seeing. However, finding the essential elements, like, for example, of anorexia, may elicit considerable debate among theorists. So when you're thinking about what criteria should be met for anorexia, there's often debate on that. And there's sometimes overlap between diagnoses, you'll see. So a dimensional system can affect insurance reimbursement if it's not clear demarcation between one mental illness and the lack of the mental illness. And so researchers and clinicians would both really need to adapt to this new approach of classifying and describing behavior, so that we are all kind of speaking the same language when we're talking about somebody's struggles or somebody's diagnosis.